All right, good evening or good afternoon, folks. Welcome to the final installation of our webinar series focused on the tools of trade, basically anything you need to know to practice sleep medicine without being a sleep medicine practitioner. I will go ahead and start sharing my screen shortly. All right, hopefully it'll come out soon. All right. Welcome, folks. This is the final installation. We started off a few months ago with back in January, where I made the interesting selection of January 20th as the first day of the webinar, without thinking that that would be the inauguration of the current president. And so it's been a learning experience, so to speak. We started off with Sleep Medicine 101, and then we went on to insomnia in February. And then in March, we tackled sleep apnea, the evaluation and testing part of sleep apnea. And then in April, we did sleep apnea, but in terms of management, treatment options, and then chronic management of these patients. And it comes to the final one that we have right now, which is Circadian Rhythm Disorders and Restless Leg Syndrome. As I said in the past, this is focused on practitioners who are not primarily sleep practitioners, just because I find that with sleep being a relatively new field, the understanding of all these issues is not only limited within the sleep field, because we're learning so much more in terms of how to manage patients, but let alone outside the sleep field. And then if you consider the fact that there are many more nurse practitioners now coming into the workforce that are managing these patients primarily, it puts, obviously we need to kind of get the word out about how sleep affects all the other medical conditions, especially when patients come to you somewhat quote unquote falling apart. And that's when you have to start thinking about what's actually driving all of these issues. I mean, the blood pressure can be controlled with one medication, the heart rate and the arrhythmias, or the thyroid dysfunction. But why all these small little fires coming out? And all you do is end up acting like a whack-a-mole when it comes to disease management. So you see this medication list that continues to get longer and longer and longer. And at some point, you have no idea what's actually a new disease versus a manifestation of drug interaction. I think that's where we kind of run into trouble. So I will go ahead and get things a little started. I think we are due time right now. Yes, we will. So this topic, and I'll be honest with you, is probably one of my more challenging topics, circadian rhythm disorders, because there's a lot to figure out, and then restless legs as well. All right, so a little bit about me. I am a fellowship trained sleep and pulmonary physician. I'm also board certified in critical care medicine. And I founded a virtual practice because I felt what I was doing could be done remotely, and it actually allowed me to see patients more frequently and easily without them having to worry about actually showing up and hanging out in a stuffy waiting room for me. All right, this was created as part of a way, like I said, to disseminate information. All these webinars are free. What we intend to do after this is actually put all of them together and then send it out as a continuing education credit for all five, which you can watch in one go. We also have these webinars, which I'll show you at the end of this, where it's located within our website itself, so that you can use that to refresh your memory, share it with your colleagues. Or if you have patients who ask incessant questions about these and they're quote unquote Dr. Google, which I admire and I think is good, you can show them the website and have them look at some of the blogs and the videos that we have. Education credits will be granted for those who complete the the post-test webinar exam that's going to be sent out within 24 hours of this completion of the webinar today. And you have a window open for 1 week only to complete the the test. There will be a recording of the webinar enclosed in that email that's sent out to everyone registered. So even if you can't stay for the whole hour, you can watch the webinar and gain credits through the American Association of Nurse Practitioners. And like I said, once you get it done, send it back to us. Give us about a week to collate the results and send out the certificates to y'all. And if you have any problems, any issues, and so on, please, if life happens, let us know. I'd be happy to help you all as best as we can. All right, so let's get started with circadian rhythm disorders or circadian rhythm sleep-wake disorders. What are they? What we're going to try to do today is actually try to understand what they mean in terms of the definition, what drives circadian rhythm issues or sleep disorders within the realm of circadian rhythm problems, how to evaluate these patients, and then how do you deal with them? Like I said, it's one of the more challenging fields within sleep medicine. The basics of it: regulation of sleep is driven by two main forces that we have somewhat within our control. One is homeostasis, which is basically how much energy you expand during the day, your activities, whether it's your brain, whether it's your body, exhaustion. All of these things accumulate during the day, the junk, the metabolites, and so on, accumulate within you, within your brain as well. That cause, as the day progresses, causes homeostasis drive to increase for you to take that nap or that sleep time when sleep time hits. Circadian rhythm is day and night variation. Our bodies as well have an internal body clock that manages that. Oddly enough, or interestingly enough, the internal circadian rhythm of the human body is a little longer than 24 hours. So if that means it's prone to get tilted off course and may need to be realigned frequently. So the circadian rhythm is basically day-night variation, light exposure, and so on. So as we can tell here, what drives a lot of this is if you're looking at the circadian rhythm, as soon as you wake up, you basically have around 16, 18-hour window of wakefulness. As the day progresses, you can see here the sleep drive here, which is homeostasis, starts increasing and increasing as you're doing more things, interacting with people, commuting to work, sending your kids off to school, cooking, figuring out how best to plan your vacation. All of these things increase your sleep drive. The circadian drive itself is driven by, as soon as you wake up, if you're in a dark room, you're not going to really feel much of a circadian drive. So circadian drive really is driven by our exposure to light, exposure to activity as well, things that wake the body up, so to speak. And you will find that this has become a bigger issue because of the fact that a lot of patients nowadays actually work remotely. They have the option of working from home. And also they may remain indoors because of COVID. Now, obviously situation here in the US stateside has been a lot better, but obviously for our friends and family and the rest of humanity that's dealing with this across the oceans, staying home and being cooped up at home is still a reality for many of them. So in this case, the general criteria for a circadian rhythm is actually the disruption of your sleep-wake rhythm. So I can't fall asleep on time, or I'm waking up too early, or I'm waking up too late, or I'm falling asleep too soon. And I'll go through this in a little bit. Some sort of complaint about I'm not sleeping the way I should or when I should. And then I end up having daytime symptoms, whether it's fatigue, tiredness, and so on. With a few of them that we have to go through here now. Advanced sleep phase is basically advanced. So if you look at the clock and the face of a clock, forward moving, meaning anything that brings your sleep phase forward, meaning advanced. So instead of going to sleep at 10 o'clock, patients are going to sleep at 6, 7, 8 o'clock in the evening. And delayed sleep phase is obviously what we consider socially later as well. So any, 12, 1, 2, 3 o'clock, a lot of patients end up sleeping 2 or 3 o'clock. I think a lot of patients will opt for ability to sleep at 12 as normal. So I think, when you look at the early hours falling asleep, I had a patient, for example, whose sleep-wake cycle was 2 to 10, 2 a.m. to 10 a.m. and he loved it. He woke up fine, and we'll go to the definitions of each one of them and explain that as well. Irregular sleep-wake rhythm disorders is something that's fairly new, and I'm seeing a few more of them now because of remote work. Whether you're dealing with teams from either side of the coast, from East Coast to West Coast, and you're dealing with some different work schedules, but also if you work remotely with teams across oceans and across different hours as well. That's when what happens is a lot of people will take naps at irregular times and be awake at irregular times as well. A lot of people within the, for example, the coding industry, when they're in the tech and coding and so on, they end up doing this because of how the work cycle works with teams across the ocean. Non-24-hour sleep-wake rhythm disorder is actually related to patients who don't have a entrainable sort of circadian rhythm. Usually we think of these patients as patients who are legally blind or more or less completely blind, and don't have the ability to kind of entrain their sleep-wake cycle. So these patients are a very difficult group of patients to deal with. Shift work disorder is probably the one that all of us will come across the most often, just because we're all in healthcare. And I think healthcare workers, I can't remember, those are a certain number, over 20% have some shift work. And I think in the general population as well, that's not too far, especially if you think about people in police officers, firemen, people in the utilities, people working in big factories and so on. So shift work disorder is a lot more common than we imagine. A lot of people will just brush it off and just assume that the way they feel is normal. Jet lag disorder, we've come across flying different time zones. And social lag disorder, I just placed there. Social jet lag is actually weekends. So if you end up going to sleep at a certain time during the week, and then weekend comes around, you put your dancing shoes on and you decide you want to sleep 3 hours later, and that's a Friday night and Saturday night to you. Come Sunday, when you're trying to go to sleep at 10 o'clock again, you're not going to be able to go to sleep. I just put that in jest. But the other one that's also commonly throws us all off course is daylight savings time as well. So we're looking for anything that changes the way our homeostasis drive and our circadian drive gets out of whack. All right. So advanced sleep phase is when we have an early timing of sleep. Earlier than expected, earlier than usual in patients. Patients say they can't stay awake past a certain point. Now, they also end up waking up way earlier than usual. The difference is these patients who wake up earlier than usual are fully refreshed. They sleep through the night well. They don't have any issues. They wake up feeling refreshed, especially if you allow them to sleep the way they want to. They wake up very early. We have a lot of the patients that I deal with advanced sleep wake disorder are patients who are older as well. So it's important in these patients to rule out other medical conditions, whether they may be taking medications that may be causing this, or also they have other health issues that may be causing this tiredness and fatigue that occurs during the day. Now, it's also important to find out if they wake up in the morning, when they're allowed to wake up as is, whether they feel like they got a good night's sleep. Now, most of them may tell you that they don't get a good night's sleep and they still feel tired. So these are patients that you actually have to scratch the surface a little bit more to figure out what's the underlying sleep disorder. And we'll talk about that in a little bit as well. A delayed sleep phase disorder, you will find that these patients are actually related. You get a younger population here, teenagers and so on. Obviously, looking at that sleep-wake cycle, we find now that later school times as well has helped them. Starting off, especially in middle school and high school. Though the recent data actually does not support elementary school wake times, the delay has not changed how the students perform and so on. But it's interesting, the delayed sleep phase is actually what drove a lot of the change in our school scheduling as well. But in these patients, they actually end up having a really significantly delayed sleep time, causing them to have school issues or work-related issues. Like I said, I had the patient who slept from 2 to 10 o'clock, and his work was great. He loved his sleep-wake cycle. He loved sleeping at 2 o'clock. He enjoyed all of that. He would wake up at 10, feel fully refreshed. We had, excluded all the other medical conditions that he could have, sent him for a sleep test as well, because there was some suspicion that he may be snoring. But all of that was ruled out, and this patient actually, I had to write a letter stating that if they could be allowed to work at 10, and the employers were more than happy for them to start because they were a great worker. So yeah, so delayed sleep phase is not able to fall asleep when socially acceptable times, and then they have difficulty waking up when they should, whether it's at school and so on. Irregular sleep-wake cycle, like I mentioned, these patients, these people are usually working a lot of odd hours because of how remote teams are working now. Obviously, there can be also project-based work as well. There's a lot of people now working as independent contractors out there, whether it's on Fiverr doing sort of odd jobs and so on to create professional work done for another company, or even whether they're driving Uber or whether they are delivering food and so on. Because of the irregular sleep, the demand of their work, they may end up having an irregular sleep-wake cycle. So consolidated sleep is what's lacking, and then they suffer the consequences of not having a consolidated sleep period, such as 10 p.m. to 6 a.m. Shift work disorder. Now, this is what I personally have gone through as well. We actually published a blog on this a few months ago. So I'll show you all this after, where you can share it with patients who have that. It kind of walks them through some of the steps that's guideline based in terms of how to manage their care. But again, patients either complain they can't sleep when they need to, they're exhausted during the day or night, and just changing from one shift to the other is difficult. So in these patients, they have shift work that's outside the regular normal shift, which is daytime shift. So they may work the second shift, which ends maybe at 10 or 11 o'clock or 12 o'clock at night, starting in the afternoon. Or they may have the third shift, which is where they work an overnight shift. And so that's brutal work. I just had a recent patient who was an EMS dispatcher, and then they were short staffed, and she had to work multiple back-to-back call shifts, which is brutal. So, and she was suffering the consequences of it. As you know, if you were around for the first two webinars, for example, the lack of sleep, then it portends to a much higher risk of heart disease and medical conditions and weight gain as well. So it's definitely something that patients, try to deal with as much as possible until they start suffering the medical consequences of their poor sleep. And we'll talk about the treatment of this in a little bit. So how do you evaluate these patients? First, what's their primary complaint? What time do they fall asleep? What time they expect to fall asleep? Why do they want to go to sleep at that time? I had a patient, for example, who would go to bed at 8:30 or 9 o'clock and said it took him an hour to fall asleep. And upon asking why, his response, and rightfully so, was, well, my wife had a stroke, and so she needs to be in bed by around 7:30. So I stay in bed with her, I try to read, and then I can't read more than an hour or so. So by 8:30, I try to fall asleep and I can't. So again, issues like that should be evaluated, because that is not true circadian rhythm disorders. That's probably just more of a sleep timing issue or a sleep hygiene issue, if you want to call it that. And so these are patients who you're trying to evaluate to see whether they have no other driving force or what's causing them to fall asleep early or not be able to fall asleep till very late. You want to assess comorbidities as well, whether it's medical conditions or sleep problems. Medical conditions in terms of whether these patients have a reasonable medical history to indicate why they may be sleepy by 7 or 8 o'clock. But then these patients usually don't wake up refreshed. In patients with advanced sleep phase disorders, they will wake up at 4 o'clock or 3 o'clock in the morning and be bright-eyed and twinkle toes, and they'll be cleaning the house and doing stuff and feel completely fine, except the fact that they don't get to spend the time in the evening or have dinner with their family, and that affects them. Again, usually we find this in older folks. Sleep problems as well, you want to rule out other issues, making sure that sleep apnea is not a cause, making sure that restless legs isn't a cause, which we'll talk about it in the second part of this talk. Making sure that they don't have any other issues like parasomnia or any other sleep behavior disorders that may actually cause them to sleep early. But the medical and sleep problems need to be evaluated. The next thing is psychiatric symptoms, because of the fact that a lot of these symptoms of psychiatric disorders, poor energy levels or low energy levels, fatigue, inability to kind of motivate themselves, early awakenings at night, for example. So all of these things, actually, you have to make sure that, especially in our younger patient populations as well, to ensure that the reason why they're staying awake up all at night is not because of some sort of underlying psych issue as well. Because I think children or younger adults tend to get overlooked in terms of their need for psychiatric evaluation, or even their problems that they may be facing, whether it's through social media, whether it's through family stress and so on, is to evaluate whether there's a psychiatric component to it. And the next, obviously, is the use of psychoactive substances, whether they're dabbling in it, whether they're experimenting in it, whether they're addicted to it as well. Because a lot of patients with sleep disorders may actually try to what I would call self-medicate. We all do it all the time with some alcohol, with Benadryl and so on, and other people do different things as well. So take note of that. Part of the evaluation should include the bedtime routine. What are they doing before bedtime? Why do they want to go to sleep at that time? How long it takes them to fall asleep? What stops them from falling asleep? Now, they'll always tell you, my mind can't shut off, but that's usually a function of their circadian rhythm and their homeostatic rhythm kind of going out of whack. Because if you're in bed and you're not falling asleep, unless of course you're a yogi or some sort of meditation guru, you will have thoughts in your head. When you're laying down there, when I'm laying down there and I'm not ready to go to sleep yet, I will be thinking. And those are, people always think that they're special in that sense that, oh, I can't shut my mind off. That's just who I am. The reason why they can't shut their mind off is because their mind is not supposed to be shut off. Whenever you feel like it, it actually takes a lot of training for you to shut your mind off. But the actual fact is that they're awake at that time and they can't fall asleep, and hence their mind wanders. So bedtime routine is important. Caffeine and alcohol use. Caffeine is interesting because how it affects you when you're younger is also different when you're older. Caffeine use can also affect you differently depending on what sort of drugs you also are using, whether it's prescription drugs or not, and that may affect its metabolism. So caffeine use is something interesting. Just because you think a friend of yours takes coffee at 4 o'clock at work and you find with that it shouldn't affect you, you may be a little bit different, and this is where you might actually be special. So take note of caffeine as stimulant use as well, energy drinks, drug use, like I mentioned before, exercise habits, or the lack thereof as well. So you want patients to make sure that they're exerting themselves. So most of these sort of work from home, remote work, patients are staying home. They don't get much exercise. They don't get out. There's no physical exertion. They may be able to take a small nap here and there, and that might delay their sleep phase because they're not ready to go to sleep at 10 since they took a 45-minute nap at 2 in the afternoon, for example. Sleep environment is interesting. Most of the time, it's pretty low value for a medical practitioner to ask or inquire about that. The reason being, most patients have already solved that on their own or try to solve that on their own. They've already spent or invested a lot of money and time into trying to make sure that they have a blackout shades, they cool environment, special pillows, special mattresses, all of these things I wish we could sell as medical practitioners, but we can't. And patients, unfortunately, have already wasted all their money before they come and see you. So sleep environment is something that, quiet, cool, and comfortable. Those are the three things you need to make sure that they have. Now, how do we visualize this? Because sometimes what a patient tells you is difficult for you to understand, but also difficult for the patient to understand where the problem may lie. So a sleep-wake schedule, even though it can be verbally described, it's best described in a visual manner. So whether you use a rudimentary PDF document that you print out and you scratch off and so on, or you use something more high-tech like your iWatch or an ectograph, which is what the iWatch uses, to capture your ability or your time asleep or your time awake. Looking at this in a visual form helps you understand where the problem may lie. What you really want to record is when the lights went off, when the lights came on. You don't need an exact time that you were awake and the exact time you fell asleep, because you don't want, the worst is you don't need an insomniac. You don't need to give an insomniac a task to do at night, because they will definitely be doing that and keeping close tabs of what time they end up falling asleep. So just rough idea what time they were awake, how long they were awake for, rough idea of how many awakenings they may have had, and the sleep time. And that, like I said, will be described to you, and I'll show you in a little bit. Take note of when they took their food. They can, annotate down based on F and C and M and A, and the patient can write their own little mnemonics or shorthand at the top of the document. This is what it looks like. This is a rudimentary form. I generally will send patients this in a PDF. The American Academy of Sleep Medicine, or AASM, has a PDF document. So I think if you Google AASM Sleep Diary PDF, you'll get the PDF. I download that and then just print that out, or I email that to some of my patients. But patients will end up coming to me, showing me with their own devices now and what it downloads. But it's for me, it at least is a start of a conversation to at least get the patient to visualize what they're doing over here. So in this patient, for example, you can see the timing on a Saturday is different from a Friday, which is different from a Thursday. So, but their wake times are early, and this is maybe someone that doesn't have enough sleep, and so they may be waking up. This is not truly specific for sleep-wake, our sleep-wake circadian rhythm disorders. But I just want to give you an idea how this patient should fill this up. And sometimes you'll see that the weekdays differ drastically from weekends, or you end up having a week-to-week change, and you realize that their shift work actually changes drastically, or their children's school schedule may change as well. So visualizing this helps both the practitioner and the patient as well figure out where the problem may lie. Now, how do we treat circadian rhythm disorders? You want to really align the circadian rhythm phase with your homeostatic phase, which is your highest likelihood of being being tired and sleepy, right? Unfortunately, if you work a shift work, then your circadian phase is completely out of whack with your homeostasis rhythm. And so you'll need to realign that. We'll talk about that in a little bit. But generally, for example, in advanced sleep phase disorders, patients are sleeping too early. Once you've ruled out any other comorbid sleep, psychiatric, or medical issues, you want to start making sure the patient's exposed to adequate light during the day, enough activity during the day, making sure they're not taking any medications that may counteract the tendency to stay awake, make sure they have enough activities lined up that allows them to go outside the house or have enough light exposure and adequate exposure in the evening as well. So early evening exposure at about 7 or 8 o'clock might be helpful for these patients, making sure that you delay the sleep phase as much as possible. Now, what you can do as well in these patients is that if they end up waking up really early in the morning, you might want to give them a very light hypnotic, but I would advise against that for now until you figure out if they can tolerate that. And because you don't want to give them anything that's going to make them groggy when they wake up, especially if you're dealing with an older patient population. In these patients with delayed sleep phase, for example, you can time the melatonin in these patients. So you can give them melatonin before but 2 hours before the desired sleep phase, depending on their dose. A lower dose generally as a way to shift phases. A higher dose of melatonin, I'm talking about like 10 milligrams. For some patients, even 5 is considered high. Maybe something that helps them fall asleep or even get more drowsy. So at least from a research perspective, the lower dose melatonin helps shift your phase forward. So when you take it 2 hours before, it makes you tired or sleepier sooner, but not in that sort of hypnotic way where you'd start getting drowsy and so on soon after. But if you take a larger dose, that's what it's meant to do. It's meant to actually get you somnolent and sleepier. So in delayed sleep patients, for example, you want to ensure that if you are trying to get a melatonin, a lower dose 2 hours before, or at least half an hour before bedtime, a higher dose if that's what works. Now, you want to also evaluate and see whether these patients have, like I said, ruled out for psychiatric disorders. Along with that, in delayed sleep phase disorders, you want to also expose them to light in the morning. As soon as they wake up, they shouldn't be in bed kind of checking their phones or trying to sleep in a little bit more. You want to get them out of bed. You can use now this newer phones, or at least phone controlled awakening alarm clocks now with light included. So it does start your daytime with scheduling the light turning on when you are supposed to wake up or when you do wake up. Now, it's not going to happen overnight. So what you want to end up doing for the patient, if they end up waking up at 10 o'clock and they desire to wake earlier, is to move back the clock by about half an hour, that their wake time, and then watch that for about a few days. I give them about 3 to 5 days of half an hour and then another half an hour, and making sure you expose them to enough light during these times as well. You may buy a light box, invest in a light box, but if you live in the Southern Hemisphere, then you don't have the problem. If you are on the northern side of the world, then you may not have adequate light exposure, especially during the winter months. So a light box investment on Amazon and so on might be helpful. These things generally, you want to get something within 2,500 to 5,000 lux, or even 4,000 lux, or LUX. That's the energy of light that they may be exposed to. Just make sure these patients don't have any sort of retinal problems. And so light exposure at the right time, especially for advanced sleep phase or delayed sleep phase patients. In delayed sleep phase patients, you may allow them some exposure to melatonin as well. Now, a little bit more about melatonin. The reason why it's kind of a shady issue is because it's not FDA regulated. So a lot of them come in sort of supplements. Now, none of these are listed here. I'm promoting in any way. Or I wish they did, but then no one's paid me. But it does allow, if you want to make sure it's a reputable brand that you get it from. The only concern is a lot of these sleep aids or melatonin packs or tablet packs don't actually have the advertised amount that they have. So that's why it's always good to go to a reputable source that you are familiar with and to get that. Now, we don't really know what the optimal dose is. The lower dose, like I mentioned, anything less than 5 milligrams or less, generally as a way to advance the sleep phase. It doesn't give most patients a very drowsy effect, but it can for some patients. So whenever you're trying anything new, any sleep medication, any sleep aid, I always recommend a patient do that on a weekend when they're not working the next day, just to assess their grogginess effect from the medication itself. And like I said, it's not FDA regulated, so what you may find or what's written may not be what they actually get. Now, sleep-wake disorder, we'll spend a little bit more time over here. Most patients will end up having shifts. If they have a consistent shift, that's great. But if they don't have a consistent shift and shifts are all over the place, it's better to have a forward rotating work schedule. Forward rotating meaning that if they take a second shift today and then they have a shift, irregular shift 2 days down, it should be a shift that's later on at night. So if they take a second shift from 3 to 11, the next shift should be the 7 to 7 shift, for example, that they take. And then the next shift after the daytime shift. A forward rotating schedule is a lot better or easier to acclimatize for each patient, as opposed to one that's inconsistent or backward rotating, because then you're asking them to fall asleep earlier when they can't. You want to avoid stimulants 4 to 6 hours before the expected sleep time, or the time they expect or wish they could sleep. Now, what we can do for shift work disorders, one is naps. You can time naps, whether it's right before the shift starts so that they actually have like a power nap. Alternatively, if work allows, they can take a short nap at work itself. And so that way, at least that recharges them. Light exposure is important, not in the daytime or when they're going back home, but light exposure at work itself is important to make sure that entrains them, their circadian rhythm with their homeostatic rhythm. You want to minimize light exposure when they're going back home, especially if they're going back home after a third shift. It's like 7 o'clock in the morning. They want to wear a cap. They want to wear sunglasses. Avoid any activities. And it's easy for us to say, don't do this, don't do that. But if they're working the third shift all the time, the daytime is the 2 hours when they're heading back home is the only time they get to do grocery shopping, pay bills, and so on. But it is good to bring it to their attention that if these things can be delayed till after they sleep or when they wake up late in the day, it might be best. So light exposure is important. Melatonin hypnotics are great to help patients fall asleep. Now, hypnotics are great to get patients to sleep longer or sleep for a longer period of time till their expected wake time, for example. However, it's not really been shown to help patients stay more alert at night. It helps them definitely sleep during the day. We're assuming that the impact is improvement in nighttime wakefulness or psychomotor vigilance, for example, to make sure that they're active and aware, to minimize any sort of issues with what you might call it, any sort of accidents at work and so on. Stimulants as well, modafinil or Provigil is approved for patients to use, especially if they have circadian rhythm disorders, especially when it comes to shift work. So stimulants like Provigil are definitely recommended. But what I would suggest is making sure the naps are optimized. For example, I had a nurse who worked weekend shifts only, and weekdays she had a family life. She wanted to kind of get things going. So we tried everything in the book, and then finally we settled on a cocktail of stimulants that she would take during the 3 days that she worked the night shifts, and that she would take Ambien or some form of hypnotics during the weekdays to help her fall asleep at the appropriate time, so that she could kind of spend time with the family as best as possible. It's not ideal, but it seems to work, and I try to avoid the hypnotic stimulants sort of within the same 24-hour cycle because the groggy effect of that or the contradicting effect of each. All right, so in circadian rhythm disorders, and wrapping up, you want to make sure you evaluate for any other comorbid sleep disorders or comorbid psychiatric issues along with medication side effects. If they do have a true circadian rhythm issue, you want to evaluate the sleep-wake cycle, see how it is, and making sure that when they are allowed to sleep on their own with their own sort of sleep schedule and wake schedule, that they're waking up fully refreshed like anyone would feel when they had a good night of sleep for 7-8 hours. Now, if they're not waking up refreshed, at that point, you start looking for other causes, secondary issues that may be lurking or maybe at cause for their irregular sleep-wake cycle. Medication use, I keep repeating that. Don't forget to look at that as well. All right, so we've covered circadian rhythm issues, advanced sleep phase, delayed sleep phase. We've looked at shift work disorder. We've looked at irregular sleep-wake cycle, which happens when you work remote or you work irregular hours just during the day itself. We looked at how to evaluate this patient, looking at their schedule, looking at how they feel, what the sleep symptoms are, evaluating underlying medical, medication use issues, and so on. And then how to align their circadian rhythm as best as possible with their homeostatic rhythm as well, whether it's shift work disorder, whether it is advanced sleep phase versus delayed sleep phase. All right, restless leg syndrome. This is another challenging topic. So I'm going to give you all a couple of seconds. Well, for me as well, to drink a cup of water here. All right, that's all. No rest for the weary, right? So we look at the pathophysiology of this disease, diagnostic criteria, and treatment options. Now, restless legs, I wrote a blog about this recently. I'm coming across a lot more of my sleep patients when they refer to me, they have already been placed on restless leg treatments, which are primary treatment. And this will be in the test as well. Even though I'm going to contradict myself in a short while saying that you should not try dopamine agonist as the primary treatment, it is still the primary treatment for restless legs. The goal is to avoid using them unless you absolutely have to. So there's other medications that we'll use. But the test question is whether they're a primary modality for treatment, and your answer for that would be yes. And I explained the contradiction that I just described to you all a little bit. So what is restless legs? It is chronic and progressive. Patients complain of sensory issues that get relieved with some motor manipulation or movement. As far as what we know, it seems to be associated with cerebral ion deficiency. Now, even if you check your serum levels, it may not show true ion deficiency. But if you're talking about someone with a total serum concentration, saturation, of less than 25% of iron saturation, TSAT, of less than 25%, then you're considering someone who's iron deficient. Within the sleep field as well, anyone with a serum ferritin level of less than 75 micrograms is considered deficient, even though I think the normal level is above 30, because the serum concentration does not reflect cerebral concentration of iron. And there seems to be a very close association with that. It also exhibits circadian rhythm or a circadian rhythmicity, where the issues tend to get worse, especially in the evening. It's associated. Now, what's interesting is that in patients with cardiovascular disease, hypertension, and diabetes, when they have the trifecta of that, their risk factors of actually having concurrent restless legs is also very high in these patients. Untreated restless legs in the sleep health study that was done a few years ago showed that restless leg syndrome actually increases your risk of heart disease and cardiovascular disease. But we find it frequently also in cahoots with obstructive sleep apnea and then other sort of sleep disorders like narcolepsy and so on. It will be associated with neurodegenerative disorders such as Parkinson's disease, because a lot of the treatment that we use for restless legs actually stemmed from Parkinson treatment. Patients with end-stage renal disease because of the iron deficiency, pregnancy, patients who are pregnant, and other neurological disorders, along with antidepressant use as well. Patients describe this in various ways. Makes you want to move, not in a good way. Some describe it as painful, creepy crawly, can't seem to get things settled in my legs. And it tends to occur mainly at night. So we'll kind of go through the definitions of these two disorders. And I've put there periodic limb movement disorder because it's frequently associated with restless leg syndrome. In patients with restless leg syndrome, about 80% of them will end up having periodic limb movement disorder. There's no actual primary treatment for periodic limb movement disorder, PLMDs. It's actually focused on treatment of restless legs, and we just use those same drugs as well. Now, most of the time, the restless leg syndrome symptoms will bring in patients to your office because that's what stops them from falling asleep. Now, how do we diagnose them? It's a clinical diagnosis, which means you don't need a sleep study to diagnose restless legs, because most of the time these symptoms occur prior to sleep itself. You have an underlying urge to move your leg. The urge does not have to be associated with I'm feeling this way, hence I move my leg. There can just be the urge itself. I feel like I need to move my leg. Now, it's different from that periodic sort of leg jiggling that you do, or jiggling that you do under the table when you're working, like I'm doing right now as well. But so it's a little bit different. There is a deep-seated urge to move their leg, and that's how patients describe it. It's to relieve. In some of them, they will go on to say to relieve this sort of sensation that I have. It occurs at rest because activity makes it better. So rest meaning whether they're in a cinema I'm not sure who goes to a cinema nowadays, but whoever is in the cinema nowadays, I'm sure those are the patients who will come to you and describe that. But they can't sit in a car when they're traveling long distances. They can't sit they can't rest when they're sleeping at night. Someone have to get out of bed and actually move their leg. It gets better with activity, so movement sort of relieves some of that strain that they have, that deep-seated urge to move their leg. And like I said, it worsens at night. Now, there are other things that may mimic this. Akathisia is kind of like drug-induced effect of some of these drugs that may cause that. Patients who are just fidgety in general, leg jiggling as well is something I described. The involuntary leg movements, kind of like, when you, for example, are falling asleep and you kick out, or you're dozing off and you tend to jerk a little bit, those are not considered restless legs. They are more or less mimics of restlessness. Now, what are true mimics is the discomfort that patients feel. And this is driven by neuropathy or leg cramps or claudication, myopathies, venous insufficiencies. And I'll describe that a little bit more, what differentiates them, because don't forget the 4 clinical criteria. And don't forget, this is a clinical diagnosis, not a sleep study diagnosis. You have the 4. You have the urge to move your legs. You have the relief of the urge that gets better with slight movement. You also have someone who it's worse at night, and when you move, it relieves that discomfort that they have. So the RLS mimics patients. Sorry, I didn't realize this is not as clear as I was hoping it would be. You have these things, but what they don't have is the 4 criteria that we described. Some of them don't have a circadian rhythm to them. Some of them are mainly muscular in nature, and you can kind of relieve or reveal that based on the history taking on what's going on with the patients. Peripheral neuropathies as well are frequent, especially in diabetics. But patients with diabetics are also prone to get restless legs as well. So it's important to figure out what's causing it, the symptoms. That's why it's important to remember the 4 criteria: the urge, the worsening in the evening, the activity relieving it as well in these patients. And you have the deep-seated urge to move the legs. So just to kind of make sure that we are familiar with the diagnostic criteria here: rest-induced, urge to move their legs, activity improves it, and also evening as well, that worsens symptoms. And while I'm here as well, I'm going to talk about, that's why it's important, if you suspect that there may be an issue with something else rather than restless legs, a physical exam is extremely important in these patients, especially if we have sort of atypical signs of it. And I'll go through that some in a little bit. Periodic limb movement disorder, and that's what we have right now, which is 85, where we are right now with the diagnosis. 85% of restless legs patients will reveal that or have periodic limb movement disorder. It basically is a sort of rhythmic movement where you actually dorsiflex your foot, and your ankle may also flex and extend and move, continuously move. And some of these movements are separated. They're not continuous. They move, and then there's a minute to minute and a half pause, and another movement, and then another movement. And so this continuous sort of rhythmic movement occurs throughout the night. In full disclosure, I actually have I have periodic limb movements, especially when I'm stressed. I noticed that, my wife noticed that I would continuously, when I would dorsiflex my foot, it would tickle the bottom of her foot, because of the way I dorsiflected where my leg was in relation to hers. And she would know that this would occur mainly when I was stressed at work and I was going through fellowship at that point and exams and so on. And probably had cut down my caffeine intake quite a bit. But that's also resolved. But I would have the PLMDs to a point that my bed sheet would get ripped apart. And that's how much movement I would do actually during the night. So just to give you an idea of how this affects, and it can affect sleep because of the disruption of periodic limb movements to our sleep itself. The movement itself can trigger a micro arousal. So patients tend to have, this is me tickling my spouse's bottom of her foot. But yes, so it does cause a micro arousal in patients. So patients who have for example, I treat patients with sleep apnea, and in their sleep studies showed that they had PLMDs, and we've treated the sleep apnea, and they had significant number of movements, which is more than 15 movements an hour. And each movement has to be grouped by four of these movements together. That's one movement in total. So there are 15 of this throughout the hour. That's considered significant, so more than 15. But anyways, patients who have sleep apnea and you get the sleep apnea treated and they're using the CPAP adequately and they're using it long enough and you verify that and so on, you may need to make sure that their PLMDs are also treated to ensure that's not what's causing their lack of improvement in their sleep symptoms. Now, how does restless leg go? Well, how you want to evaluate them? Firstly, the complaint. What's stopping you? Most of them can't fall asleep. The ones that come to you are pretty severe. They'll explain everything to you already, but you want to ensure that in your insomniac patients or patients coming with insomnia, that you evaluate for restless legs as well, because you really have to ask them what's stopping you from falling asleep. What's causing you? Whether it's racing thoughts, whether it's pain, whether it's discomfort, whether it is restless legs, and so on. Symptoms as well, it's important to know that it has to be in both legs. It doesn't have to be simultaneously, but it needs to be involve both legs. So it can be consecutively, meaning one leg affects them first and the other leg, and it goes back and forth. Sleepiness is also an important factor, which we don't find in restless legs. Compared to sleep apnea and some other sleep disorders, patients with restless leg will not tell you, doctor, I'm so sleepy, I'm falling asleep in your waiting room. These patients tend to have a hyperadrenergic sort of state where they seem to be in this twilight zone of being tired but not sleepy and just being restless and not being able to, and I don't mean restless in a restless leg type of way, but just feeling uneasy. These patients also will complain of not being able to fall asleep, but I think the hyperadrenergic state is also what drives a lot of their cardiovascular disease risk factors. Looking at their sleep hygiene history as well is important when we're evaluating them, making sure the sleep-wake cycle is regular, because any stress, any issues that come up may actually increase their likelihood of getting restless leg. Sleep hygiene as well in terms of what they're consuming before bedtime or close to bedtime that's acting as a stimulant. Bed partner history is important. Family history is extremely important in restless legs as well because of genetics. Now, obviously genetics, but what we find is in patients who have a family member, they have a much higher likelihood of having restless legs. I think, example, if your parents had it, I think it's like a 60-65% chance, if I remember correctly, but I may stand correct on that amount. But there are strong genes associated with this. So family history is not a bad thing to get as well in these patients. However, understanding of what restless leg syndrome was 30, 40 years ago may not be where it is now. So even though your family member may have had it, no one just recognized it at that point. Evaluation, like I said, look at their diet, what they're consuming, what triggers their restless legs. Oops. And so you want to look at medications such as SSRIs as well. Bupropion seems to have the least or the best side effect profile in these patients. You don't want to try cocaine. Definitely not recommending that. But if you see it on the MAR, which you will never see it on the MAR, I don't know, you saw alcohol on the MAR at one point in hospitals to treat alcohol withdrawals. But yes, I kid. Antihistamines as well in these patients, pseudoephedrine, dextromethorphan as well is important. So anything that you look at the medication list that you see over here, you need to evaluate, obviously track them with their timeline or where their symptoms started as well. Some patients will get this and they will, for whatever reason, they have started having allergies because they moved and started taking Zyrtec. They may not tell you they take Zyrtec or one of the decongestants because they just consider that over the counter as well. So important to kind of rule out all of that as a possible cause. Now, if you have someone with atypical symptoms or symptoms that you suggest, maybe shooting pain, sciatica, back pain, and so on, you want to make sure you do a full examination of them. But most of the time, a clinical diagnosis is adequate, and then you can do a physical examination if you also feel there may be other concerning issues with their history that may indicate, whether they have claudication or so on. Now, how do we test? What do we test in patients with restless legs? Well, the first thing you want to do is just make sure that you run through a basic panel. Now, pregnancy as well is important, especially in the patient, the right patient, because pregnancy increases your risk 2 to 3 times compared to a non-pregnant patient. Liver and kidney function is well important because, again, uremia and so on may lead patients to have odd sensations, so on and so on. But it's also to give us an idea of what medications we may use to treat them. The CBC is done to see whether anemia Hence, iron deficiency may be at play, but you want to get an iron panel and make sure that you do a serum ferritin. Sometimes serum ferritin levels may not be indicative because serum ferritin is a acute phase reactant, and may be falsely high if someone was recovering from a recent illness. So that's when you use the TSAT, or the serum saturation, of the transferrin saturation, and it is less than 25%, you may need to consider whether they have iron deficiency. And supplementing that, which we'll talk about in a little bit, helps. Thyroid function, vitamin D, B12, and folic acid. Again, if you can figure out that that's what's causing this, go ahead and treat that. There may be other issues at hand. Now, do you need to order a sleep study? No, you don't. The only time you have to is to figure out if you're unsure of the diagnosis of restless leg. It seems to be out of proportion to their sleep complaints, for example. Or if you're thinking of obstructive sleep apnea, of any other sleep disorder that you need to evaluate via sleep study, then go ahead. Or if you treat them, for example, like I described my patient, where you might treat it with someone with a home sleep study. He got a CPAP, auto CPAP, so he never touched a sleep lab at all. And then he went to the sleep because of the persistent sleep disruptions that he had. He kept waking up and I couldn't tell what it was. And even when he was sleeping, trying to sleep 7-8 hours continuously, I sent him to the sleep lab. And that's where we found he had significant PLMDs, which we treated. We checked him for his iron levels. It was low. Now that's a happy ending. Sometimes you don't have happy endings that are easy enough that you can treat with iron. And that's what we're going to get into. So the treatment considerations, obviously you want to quit anything or stop anything that may be somewhat reversible, that may be causing some of the symptoms. So look at the medication list, recent medication list, even what the PO intake of over-the-counter medications, drugs, whether it's herbal supplements. Ask them about that, any change in diet habits as well. Next, you want to check the blood work, especially paying focused to the serum ferritin level. Severity of frequency and severity of the symptoms are important because it helps decide how hard you want to hit the patients because of the side effect of dopamine agonists. You want to look at comorbid medical conditions that may be driving some of it. You also want to look at non-pharmacological treatments, which we'll talk about in a little bit, in terms of how do we manage this without actually jumping to medications. First, if we can discontinue something, or if you can try to get them to move around, exercise a little bit more, that might help. But I'll warn you, most patients that come to you are not mild enough that these sort of non-pharmacological treatments. But when I talk about non-pharmacological, I'm also including iron supplement. But I'm talking about leg massages and warm foot baths. It might act as a good adjunct, but on its own, it's not going to treat or be the silver bullet that's going to help these patients. And if you have to start pharmacological therapy, we'll start at the lowest dose, and we'll talk about that a little bit. Iron supplement. So you check a patient and the serum ferritin is less than 75 microgram. You start iron supplementation. You check the levels 3 to 4 months after that. Please take note that patients don't tolerate iron very easily. So make sure that you try things like iron polysaccharide, which is a different elemental iron formulation that might be better tolerated in these patients. In patients with severe symptoms, you may consider IV iron supplementation. It's more expensive. Make sure it's covered by the insurers. You don't want to check it before 6 weeks because it's not going to be you're not going to give it adequate time to increase. You want to keep it above 75. So what I normally will do is once it's above 75, I will have them continue that for another couple more months before I recheck the level. It stays above 75. I discontinue the iron ferritin level, and then I check them 6 months later just to make sure they're on track. Or if their symptoms recur, I start them. I check the levels again after that. All right, if your iron saturation is above 50%, please stop because you don't want to cause more harm to these patients. Like I said, the kind of pills or how you deliver the iron supplements you may want to be familiar with different forms of iron because of the poor tolerance with regular ferrous sulfate. So you may want to combine it with vitamin C. I think most of y'all know this at this point, but that intolerance to the drug is what causes them to discontinue. Plus, they're going to have dark stools, so you want to give them an idea that that's going to happen. If not, they'll freak out. Like I said, what are other non-pharmacological therapies apart from iron supplement? Exercise in the evening might help. Too strenuous exercise before bedtime and be counterproductive, but moderate exercise in the evening might help patients. I recommend, if patients are working remotely or working at a desk a lot, you may want to use one of those stepper desks where you can actually, it's like a cycling wheel that you cycle on. It might help relieve some of the strain. Again, it's not going to be what cures them. Now, if you've tried the non-pharmacological aspects, non-pharmacological treatments, and you've exhausted, iron supplementation, you've checked the serum levels of B12 and thyroid and folic acid, and nothing's really treated. Again, if this patients are mild, then you will start this after you've gone through all of that. But if someone comes to you very severe, that they really can't fall asleep, they're miserable, you may want to do both at the same time, which is considered drug therapy, non-pharmacological and pharmacological therapy at the same time. The recommendation recently is to go start off with drugs such as your alpha-2 delta ligand, and these are these three drugs over here. Gabapentin, Inacrabil. I much prefer the trade name, which is Horizon, is a good drug to use. It's also if patients complaining of pain. These are the three drugs you can use in these patients. Like anything that's sedating, I always tell patients to take it on a weekend, especially if they don't have to work the next day. These are the drugs that I recommend as a first line to most patients with mild to moderate to maybe severe disease. But if it's severe, that they have symptoms every night, stopping them falling asleep, at that point, I would say maybe start off with, which I would do is the dopamine agonist, pramipexole or opinirole. Requip, you can use them in renal patients, and pramipexole, you can use them in liver patients. These are the dosings that you can use in these patients. It's good to start it treatment an hour to 2 before symptoms start. It's very difficult to treat restless legs if your symptoms have already started. So you want to find out what time these symptoms normally occur so you can time it accordingly. So that if a patient says, it's when I get into bed at around 9:30 at night, you may want to actually give them the medication by about 8:30 at night to make sure that it's adequately absorbed in their system to have their positive effect. All right, so what else can you use? You can, apart from dopamine agonists, and then you want to up the dose accordingly, but you want to find the lowest minimum dosage of that patient. So even the patient says they have complaints, if the complaint is like, hey, I have breakthrough issues once or twice a week, you may want to actually add a gabapentin or a Horizon or a Lyrica or pregabalin to that medication regimen, because you don't want to increase the dopamine agonist all throughout the week just for 1 or 2 nights of breakthrough issues, because that increases their risk of side effects such as augmentation and also medication side effects as well. So if you want to, the couple of breakthrough symptoms, you can supplement the dopamine agonist with these 3 drugs. Again, if you have the comfort level, you can also do benzos, clonazepam or lorazepam. Might actually be beneficial in some of these patients on one of those 2 nights or 1 or 2 nights where they have breakthrough symptoms. You can also use opioids. Again, there's going to be some difficulty prescribing that and so on. It depends on how severe your patient's symptoms are. The goal is to avoid increasing the dose of the dopamine agonists, which do a good job, but then also tend to cause some worsening, sometimes few months, sometimes many years down the road. And something called augmentation, which we'll talk about. Now, if you have patients with very sporadic symptoms, like they're symptom-free except for 2 times a week, once, 2, maybe 3 times at most, I would suggest carbidopa-levodopa combination symptomatically in these patients. But if you're going to use someone, if it's going to be someone that says, I have symptoms nearly every night, then I would suggest your first line being the the alpha-2 delta ligands, which is gabapentin, pregabalin, or gabapentin and acrabil as first line, and then increasing it or changing it to the dopamine agonist if those don't work. Now, augmentation is a big issue we find in dopamine agonists, but the rotigotine patch, which is also called Neupro, Neupro, that's the trade name, that is helpful in these patients. It also causes less augmentation. So they're helpful. Like I said, so that's why trying to avoid dosage increases is helpful in dopamine agonists, because it reduces the likelihood of them developing augmentation. Symptoms or serious side effects, and that's why I was concerned. That's why I wrote the blog recently, was because I found a lot of patients being put on dopamine agonists, but upon questioning, I realized a lot of them were not being monitored for the side effects, which were patients were actively facing. And so I had to actually back off on the drug. So it causes impulse control. We'll talk about this in a little bit. And it also causes augmentation, but it can cause you to have hypotension, sleepiness, sleep attacks, hallucinations. So that's why in the older folk as well, you want to be careful on how you recommend these treatments of these drugs. So you want to always try to keep it the lowest dose, or supplement it with a second medication that might allow you to keep that dose stable without having to increase the dopamine agonist, if dopamine agonists have been the mainstay of that therapy. Now, what are impulse control disorders? Online shopping. Doesn't have to be, you don't have to go to the mall nowadays. So someone who can't stop shopping, spending large amounts of money, pathological gambling, again online, or hypersexuality. So in these patients, for example, you want to keep checking to see whether that's an issue. And if that is an issue, you need to discontinue the drug. We're finding that these happens, or at least starts happening, or patients complain of it many months into it. So take note about any sort of behavioral issue and go through that whenever the patient comes in for a visit. What is augmentation? So you start the drug like a dopamine agonist, like a ropinirole or a pramipexole, which is pramipexole is Mirapex and ropinirole is Requip. You increase the dose. It seems to actually improve for a little bit, and then the symptoms worsen after that. You increase the dose and it worsens the symptoms. Now, what happens is actually counterintuitively is you reduce the dose, and that dose, actually the symptoms improve. Another complaint is that, oh, I need to take my doses more often. I was taking at 8:30 at night and it was fine before bedtime, but now I'm taking 8:30 and then a 9 o'clock dose. All my symptoms are starting at 6 o'clock in the evening. And these are all like, the concern is, the issue is trying to differentiate between the progressive nature of this sensory motor neuron issue versus a disease due to, or the effect of a medication. So it's sometimes more difficult, but you can break up the doses into two smaller doses and split them apart. But if you start having to increase the dopamine agonist, at that point, you should be worried about something called augmentation. Now, what is RLS? We'll kind of run through this again. It's progressive. It's a clinical diagnosis, so you don't need a sleep study. 10% of the population, estimated between 5 and 10% of the population have it. It frequently goes unnoticed because it's not something that patients complain about, especially if there's so many other issues. But the more severe forms of the disease will definitely be something patients bring up to you, because it is a unrelenting problem that patients are miserable. They can't fall asleep. They can't stay asleep. Women tend to be affected more than men. It occurs more often in pregnancy, increases with age. Children can have it, especially if there's a genetic predisposition from their moms or dads and so on. And the genetic component, that's where I remember the 60% from. So if you have RLS, there's a chance. Now, if someone young or someone has iron deficiency, I want you all to remember, don't just say, oh, iron deficiency, let me go ahead and supplement it. It's to also make sure that you work up, or you let the primary care doctor know, or if you're the primary care doctor, to figure out why they may be iron deficient as well. Whether it's heavy menstruation, whether it's some sort of GI bleed, whether it's a poor diet, all of this needs to be looked at as well. I don't want you all just supplementing and not asking the question, why is my patient iron deficient? What else? We know that it affects quality of life. We've seen this in study data that show that it affects patients in as bad a way. If you have Parkinson's disease, multiple sclerosis, if you think these are all big diseases, patients, when they're questioned, will tell you that restless legs are equally bad as compared, especially if they have both Parkinson's and restless legs. They can tell you which one's worse. So it's comparable in terms of the impact and quality of life. The circadian nature of it, which is always kind of take note of. The fact that there's an iron deficiency, which affects dopamine dysfunction. Now, if you treat someone with dopamine agonists and their restless legs do not improve, you have to pause. I warn you, you have to pause and question whether you have the diagnosis correct. Because if you treat them with dopamine agonists, you should see some improvement. If you don't see any improvement, you should question your diagnosis. First line of therapy is the alpha-2 delta ligands. And again, the dopamine agonists are the mainstay of therapy. Most patients, when they progress, they will end up being on that. But it's important to keep the dose minimum and to fend off side effects of medications, along with the augmentation effect. All right, we'll come to the end. I think sorry, I went a few minutes over. This is the references that we have. And I appreciate the hard work that people way smarter than me have put into it to give us all our knowledge on restless legs and circadian rhythm disorders. We're still learning about it now. And I want to give you my contact details as well. If any of you have any questions, email us. You can reach us out on our website as well. but go ahead and email if you have any questions specifically. But what I also wanted to show you at this point was oops, no, this is what I wanted to show y'all, is our blog section as well in patients. If you want to direct your patients over here, this is one about restless legs, about how I would come across patients that I feel are not being evaluated for non-pharmacological therapies before we jump to dopamine agonists. They're not being tried on alpha-2 delta ligands as well as a drug option before jumping to dopamine agonists. So this is a question about that, but we write and blog frequently about issues that we see within the intersection of sleep and our health, and pulmonary and our health as well. Again, over-medicating our children is something called restless sleep disorder as well, which is a newer diagnosis, but one that I think will help reduce our reliance on medications on a lot of our kids as well. But if you have patients who have questions about their CPAP use, what issues, troubleshooting, and so on, we do have frequent blogs over here. We also have, by the way, if after this, we will publish the webinar here. So if you want to share it with anyone, or if you feel like there's something you need a refresher course on, you can go ahead under resources, just go to webinars, and you will see a whole link of the video should appear here eventually once it loads appropriately. But you should find the videos here to watch, and you can click a link and so on and just watch that. I swear to you, once it stops rotating here, it does actually show up. And the other link that you might find helpful for your patients as well is teaching videos. We have a lot of resources here in terms of troubleshooting issues with CPAP use, in terms of how to set up your filters, how to set up your CPAP appropriately, if you have issues with your face mask, how to troubleshoot that, what a home sleep study looks like. Now, if you're a practitioner that always wants to learn as well, there's a whole bunch of teaching videos here on, how to deal with sinus congestion on CPAP. What is a mandibular advancement device for sleep apnea? If patients are not liking CPAP, what do you need to do? How to deal with bloating and flatulence? Also respiratory issues as well. When to order a repeat spirometry, when to do a low-dose lung cancer screening, how to read a chest x-ray, how to interpret a spirometry, or what's the difference between the spirometry and pulmonary function test. But anyways, I digress. I just wanted to show you all that to kind of end our 5 run of our webinars that we were providing for free for most of y'all. And please feel free to share this knowledge. We're sharing it out for free. Look out for the post-test that should be sent out to you within 24 hours for you to get your accreditation points. And if you all have any questions, if there's anything that's patient care related, please feel free to consider this your pulmonary and sleep home. We're more than happy to answer any questions, help patients out, even if it doesn't mean that these aren't our patients, they can use our resources. We're more than happy for them to do that. Yeah, I think we're going to sign off appropriately at this point, unless, of course, anyone has any questions. So if you all have any questions, please shoot. I think I see. Okay. All right. I'm sure you'll be able to see my screen. But anyways, if anyone has any questions, I don't see any questions addressed. So we will go ahead and end this visit or end this session right now, and breathe well and sleep soundly, folks.